All right, guys, we're going to go ahead and get started. Monica, I have the second half of the didactic that you started the last time.
Okay.
So maybe if you want to give like a brief reminder for what we started with. But otherwise, we'll just go into that. Real quick, we'll do introductions. I see Lucy has introduced herself. She doesn't have a mic, but she's here. Let's see. Rachel, do you want to go? You are muted. It's not letting me unmute you. All right, no worries. Okay, and Monica.
Rachel might not be able. Rachel's one of our PharmDs for heart failure. She's in a course today, so she might be.
It might be somebody else.
Yeah. She's probably looking and trying to do some other stuff. So.
Okay. Do you want to introduce yourself, Monica?
So I'm Monica Thomas. I'm the LVAD coordinator at WVU Medicine.
Awesome. All right, and I'm Caitlin Ettinger, the West Virginia Project Echo Coordinator. Funny enough, Dr. Sokos is here with me, but he's doing other stuff.
Yeah, I figured he was busy.
Yeah. So we'll go ahead and get started. Monica, I'll share your stuff and just let me know when to click through it, okay?
I think we left off on like slide 18 or something.
All right.
Oh, here we go. Okay.
Yeah.
So we'll go ahead. I talked last week and spoke about, LVAD's left ventricular assist device, and kind of went over an overview of, what is an LVAD, appropriate referral for LVAD, which we'll get a little bit more into that in these slides, and talking about the management of patients with LVADs. So talking about how to manage their equipment and stuff. So this kind of goes into the management of a patient with an LVAD, really important. We really like to make sure that we're managing the blood pressure on these patients. These patients, the LVAD is just a left ventricular assist device. So we'd like to make sure that they have an appropriate blood pressure management, because if you saw last week's video, these pumps are, preloads, they're very preload dependent and afterload sensitive. So really important that we have a target Doppler pressure of about 70 to 80 millimeters of mercury and not letting that number exceed 85. We talked about these being continual flow devices and the inability to get a normal blood pressure on these patients as you would in a clinic or hospital with an automatic cuff. We use a Doppler and a manual blood pressure cuff. And then knowing that if these patients are hypertensive, you will see a decrease in forward flow, and you will see a decrease in flow on the pump as well as power. So we manage their hypertension in order to optimize their cardiac support, and it also reduces their stroke risk due to hypertension. One thing to know about these patients when you come in contact with them, or if you're managing care for other reasons with these patients, that they are anticoagulated. They do have mechanical support implanted in them, so they are on aspirin. They're on warfarin, and then sometimes you'll see another antiplatelet agent on these patients, such as Prisantine, Plavix, or Volenta. Our patients right now have a goal INR of about 2 to 3, and we keep that pretty tightly managed. We manage the INRs within our clinic. Our pharmacists are very involved in our management of our LVAD patients. One thing we tell everybody, these patients come to you, do not reverse these patients. It could clot the pump. So we're really hesitant to do any reversal of their INRs unless we're dealing with a life-threatening bleed, then we could discuss it. And we're hesitant with blood products in these patients. If they're a candidate for cardiac transplant and they can get put on a transplant list, or they are on a transplant list, we really try to avoid blood products, because we start to introduce new antibodies into these patients, and the chance of them getting a donor heart can be affected by that. So we watch that as well. Big thing with these patients, if they show up in any of your clinics or you run into an LVAD patient and you're trying to manage care, contact the LVAD team. At the end of this slide, I give you all our contact information, because there are several patients in the state of West Virginia with LVADs. You can go next, Caitlin. So arrhythmia management, so medical treatment with the exception of chest compression. So we follow BLS, ACLS protocol. We give these patients amiodarone, lidocaine. We do cardioversion and defibrillation. It doesn't interrupt the pump or the support. The thing with chest compression, so we say with the exception of chest compressions, if the pump is running, we do not do chest compression. So if you look at the system controller where the green arrow is pointing, there's a green circle of life. That's one way that we know that the pump is running. And then another way to know if the pump is running, if you auscultate on the patient's chest, you will hear a VAD hum. It is a very distinct sound that is not lub dub, lub dub, lub dub. It is a continuous sound. The HeartMate 2 is a very monotone sound, whereas the HeartMate 3 is more of a harmonious sound, but is a definitely mechanical sounding, definite hum sound that you hear. So those are the two ways I always tell patients when they find a patient that's, say an unresponsive patient, what's going on here? Is the pump running? And if the pump's running, chances are there's something else that's causing, when you go through your H's and T's, think of something else that could be causing this, because if that pump's running, it's supporting the patient. There's one of the numbers we always tell in a true emergency, contact us. We do have a coordinator on call, page your number there. So you can go next, Caitlin. So right here is the HeartMate 3. This is the newest pump on market that they just approved for long-term use or destination therapy in October of 2018, and it is used for bridge to transplant as well as destination therapy. So we'll get more into those components. It's fully magnetically levitated technology as opposed to the axial flow of the HeartMate 2. You can go next, Caitlin. So just some features of this new pump. We actually just implanted one of these pumps, the first one yesterday. So it is fully magnetically levitated. It does have larger gaps in the pump itself to kind of prevent blood trauma, to reduce the risk of the instance of pump thrombosis. They build in an artificial pulse. It doesn't affect hemodynamics per se, but what it does is it increases and decreases speed of the pump every 2 seconds to help with blood washing, to prevent clotting, as well as there's textured blood contacting surfaces to help reduce clot to the pump itself. It does have a wide range of operation. It does a 2.5 liters to 10 liters per minute of support. It is a centrifugal style pump. And then they designed the pump to be a little bit easier for surgical attachment to the apex. So these pumps are, if we talk from the last lecture, they are surgically implanted into the apex of the left ventricle. So it is a smaller pump, and it actually attaches into the, attaches to the pericardium, whereas the HeartMate 2 was a larger pump that kind of sat in the intra-abdominal cavity. And they did do a modular driveline as well with these pumps, which was nice because over the course of time with the patients with destination therapy that had these pumps for a significant amount of time, the drivelines would break down and wear down. So they made a modular component to this driveline where if part of the driveline starts to break down or wear out, we can disconnect and put in a new driveline without having to bring engineers in or do anything extensive to that. So it does cause for an extra safety feature to make sure that that driveline attachment is locked and in place. Another feature of this pump is that the controls and the parameters of the pump are stored in the pump itself as opposed to the system controller. So now the system controller's responsibility for this pump is to provide power, whereas the previous pump, it was power and the computer system as well. You can go next, Caitlin. So here are the system components. The controllers are very similar between the two pumps. That does have the words on there that tell you HeartMate 2 versus HeartMate 3. And then there's a closer look at the pump itself and the modular cable of the driveline. So there are actually two pieces to that. You can go next. And this shows you here the pump. The first little slide there shows you how the pump is implanted in or connected into the apex of the left ventricle. It is a much smaller pump. The outflow graft still ties into the ascending aorta. So still same concept, pulling blood from the left ventricle, going into the ascending aorta. And you still have the external components. The driveline still exits the abdomen, one side or the other. It is now modular. It has a locking mechanism to be able to replace that. The system controller and the batteries are the same size, same weight as they were with the previous pump. So still that extra equipment external of the body that the patients have to care for, as well as that driveline that they have to worry, keep covered and worry about risk of infection and do sterile dressing changes on that. But the batteries it's the same 14-volt lithium-ion batteries, but since the pump runs at a lower speed, less power consumption, the batteries on this pump are lasting a lot longer than the previous pumps. So they're getting up to 17 hours of battery life. So it does pull simultaneously from the two batteries, but they're lasting about 17 hours before they have to replace them. But they always have some backup. I always tell them backup battery, backup controller with you kind of at all times. You can go next, Caitlin. So this shows you, this is the Momentum trial. It's the 2-year outcomes for the HeartMate 3. They presented this data at ACC in March of this year. And survival, at 2-year survival with the HeartMate 3 LVAD is 83%. The stroke risk is 10% at 2 years, and suspected pump thrombosis is 1%. So it's a big significance. We get a little further into where this falls with transplant as well as the previous LVADs. So you can go next, Caitlin. So this shows you here the standard of survival. So the HeartMate 3 is at 83% of survival after 2 years, right on par with transplant, which is 82%. The previous HeartMate 2 prior to 17 was 68%, and then from 2018, 76. Optimal medical management at 2 years is 41% survival. You can go next, Caitlin. And then this shows, this is why I do my job, truthfully. The whole purpose of this and doing this to these patients and putting a assist device in them is to improve their quality of life. And I do, pre-assessment quality of life, and like I do intervals 6, 12, and annuals to see, have we improved this patient's quality of life? What does their 6-minute walk test look like pre-LVAD, post-LVAD? What's their NYHA class look like now? Now they're a class, where they were a class 4, now they're a class 1 or 2. And then what's their overall, quality of life, and how have we improved that? And, the studies show that we do improve patients' quality of life over time. You can go next, Caitlin. So here's what you're going to see in these patients. So after these patients get LVADs, it's great that we can improve their quality of life, but that doesn't come without risk. Of course, we have the risk of surgery, and then they get the LVAD implanted. We get through the critical stages, and these patients go home and live on an LVAD. But what happens to them? They do have adverse events. Bleeding's a big one. GI bleeding, hemorrhagic stroke, nosebleeds. There's several reasons these patients bleed. One, continual flow device. It causes AV malformations. You also see with these patients, they are on anticoagulation. There's platelet dysfunction. So you do see a lot of GI bleeding and nosebleeds, hemorrhagic stroke as well. Infections, another risk factor for these patients. They have a cable coming out of their abdomen, one side, either the right or left side of their abdomen. We do teach them to be sterile dressing changes, keep that driveline exit site covered, make sure we're keeping it clean and dry and covered. The first sign of anything red or any, drainage from it, give us a call, let us look at it, but they still get driveline infections. They end up sometimes with bloodstream infections, and they could also get a pocket infection. And then clots, device thrombus, that was really big, and in the HeartMate 2 LVAD had a pretty high, I think about a 15% pump thrombosis rate. So, we keep these patients on anticoagulation, and, I think a lot of the new design of the new pump was to prevent this pump thrombosis. And then stroke. These patients do stroke. Thromboemboli can come from a device thrombus. It can come from something else, but you will see these patients. I just talking to my interventional radiology folks, they've put a couple home catheters in my patients that are on either IV antibiotics or dobutamine, and they're like, okay, we're getting used to this. I was like, okay, let's get ready, because you're going to start, as these patients, the longer and longer on support, it's not kind of, if they have a complication, it's when, and they're going to start seeing the stroke. So it's kind of getting those guys ready for the, the 3 a.m. stroke page and it being an LVAD patient. And then typically what you see about 1 year after surgery, about 5 to 6% of these patients are readmitted to the hospital. 1 in 10 have a disabling stroke. 2 in 10 develop a device-related infection. 2 in 10 have a serious bleed that requires medical attention, and nearly 1 in 10 may need surgery again to replace their LVAD. One thing with the serious bleeds that require medical attention, we've seen, significant amount of these bleeds. It just becomes, sometimes frustrating to the patient, because although we fix the bleed, I told you they're on Coumadin. Of course, then we try to, keep them in the hospital a lot longer than a typical patient with a GI bleed, just trying to get their INR therapeutic and monitor that they don't bleed. So it does come, some of these complications, although aren't, life-threatening, or we get through the life-threatening piece, it's kind of like they hang out with us in the hospital, and then I, always say I've kind of affected their quality of life during that stay, but they become, family to the nursing staff. They come and actually visit our nursing staff frequently, because, we see them a lot in clinic and such. Caitlin, you can go next. And then some key adverse events here that they've seen after the 2 years. So if you look at pump thrombosis, neurological events and bleeding, like top 3 key events here. So what you see with the HeartMate 3 is the suspected or confirmed pump thrombosis is 1.1% at 2 years, where the HeartMate 2 was 15.7%. And then the stroke rate is actually down too, whereas it's a 10% for the HeartMate 3 and it was almost 20 with HeartMate 2. And then bleeding, I mean, if you look at GI bleeding, it's about the same. So a lot of that too, we've put it, you know, they've changed the pump, the style of the pump and the how the pump functions with using a centrifugal type pump, but we've not changed our anticoagulation. So they're doing some research right now to see, you know, the anticoagulation and if that'll change here in the coming years or not. So we can go next. You can go next, Caitlin. Oh, it's clicking through all that. Okay, I saw what was happening, sorry. So then this just shows you some other adverse events that we talked about: sepsis, driveline infections, you know, right heart failure. That's a common adverse event, not common, but it is an adverse event that we see in these patients. You know, arrhythmias, you'll see renal dysfunction, hepatic dysfunction. So these are just kind of a breakdown of that. So you can go next, Caitlin. It's going to jump through all this again. All right, so just an overview, a conclusion of the Momentum 3 trial. I said they presented that, you know, at ACC, if anybody was there and got to see that. But the HeartMate 3 did prove to be superior to the HeartMate 2, improving survival and device removal for malfunction. 83% of the HeartMate 3 and 76% of HeartMate 2 patients were survived at the 2-year mark. And heart transplants, I think, at 82% for 2 years. HeartMate 3 patients did have a significantly fewer strokes. I think it was 10% of HeartMate 3 at 2 years and 20 at HeartMate 2. The pump thrombosis rate, which is a big one here, is at 1% for HeartMate 3. And they didn't see a correlation between stroke rate and blood pressure control in the Momentum 3. And then just proved that patients experienced significant improved functional status and quality of life scores. So we can go next, Caitlin. So this just kind of shows you, you know, the complex weave of the neurological, the stroke events, GI bleeding, and pump thrombosis, and just kind of how we deal with this. There are pre-implant risk factors that you see, you know, female sex, AFib, history of a previous stroke, but just trying to manage all this as well as keep these patients on, you know, anticoagulation. So, you know, it is something that we kind of constantly look at and watch with this patient population. Next, please. So just kind of key points with LVADs and what I want people to realize, and what I train on my staff here, anybody that would come in contact with these patients. Real important to get a Doppler pressure on these patients to know what it is. I always say, patient with chest pain comes into the ER, what's the first thing we do? We get an EKG. LVAD patient comes in the ER, what's the first thing we do? We get a Doppler blood pressure. Gives us an idea of where they're at. You can put these patients on a monitor, put them on telemetry, get an EKG. Their rhythm is their rhythm. If you see them in you know, VFib and they're talking to you, that's real. You know, it really could be real. These patients are supported. They do have left ventricular support, so they will tolerate these arrhythmias a lot better than a normal person. But we don't want them in these rhythms. They put them at risk for, puts them at risk for clot, which puts them at risk for stroke. Pulse ox should pick up on these patients. You should get a heart rate, or get a heart rate and a pulse ox saturation. One thing with putting these patients on EKG, sometimes you have to be a little creative with where you do lead placement. I told you we have a HeartMate 3 patient in-house right now, and we went to do, as soon as they got him on a monitor up in the ICU, the artifact was pretty bad on the monitor. So we just had to kind of move the things away from the chest a little bit and away from the apex, just to kind of get a less artifact on the monitor. These patients cannot have MRIs. There is magnets in these pumps. They can go to CT scan. They can get X-rays. That's totally fine. No wanding, no metal detectors, no swimming. They can take showers once things heal, but we don't let them submerge themselves in water. No hot tubs, no beaches, no pools. And then CPR, we do advise against CPR, especially if the pump's running. There's the risk that the cannula gets lodged. And then one thing, if these patients show up in your clinic, in your hospitals, or, you would run into these patients, the caregivers, the patients, if, alert and oriented, as well as the caregivers, are probably they know everything about these pumps. They live with them every day. They take care of them. Every time I see them in clinic, it's all about re-education and making sure they're the most knowledgeable people with that pump, because they're the ones that have to handle that pump every day. So they're a great resource person to you. We can go next, Caitlin. Okay, so we'll get into patient identification in terms of who needs advanced heart failure therapies. Next. So we talk about NYHA classifications for these patients. We know class 1 to class 4. A lot of the patients, by the time they get a pump, they're the 3B class 4 kind of patients. Another thing that we look at too is the INTERMAX score on these patients. And these 3B4 patients, we rate their INTERMAX score based on, symptoms and how they're doing. So they get an INTERMAX score of 1 being they're critical, they're in cardiogenic shock, up to, INTERMAX 7, which just is like an NYHA class 3 symptoms. Ideally, you want to VAD patients that are INTERMAX, 3, 4, 5. By the time you get to INTERMAX 1, 2, these patients, the research shows these patients have poor outcomes, increased lengths of stay. And I'm not saying we don't VAD these patients, because we do sometimes we have to, but they do in the long run overall don't do as well as if you can if you can VAD a patient that's INTERMAX, 3, 4, 5. So that's always really important. We always do look at that. So early referral is best. We go next. So the multifactorial treatment approaches. So non-medical therapy options should be considered for patients with advanced heart failure. We tell them quit smoking, weight management. We do track fluid intake, heart healthy diets, physical activity. We try to get these patients in, if they can tolerate, if our heart failure patients can tolerate cardiac rehab, we get them into cardiac rehab. We do focus a lot on diet, weight management, blood pressure management. We send them home with scales. We send them home with blood pressure cuffs so they can monitor all this stuff. And that's heart failure patients as well as VAD patients as well. And then of course, medical management for these patients, as well as what can we do in terms of implantable devices, ICD, CRT. We do a lot of swan placements when these patients are in the ICU, or we do right heart casts to make sure that we can optimize medical management, checking their valves if they need valve surgery. And we look at that, we really look at this stuff a lot in depth when we're getting ready to do an LVAD patient, because if we're going to open their chest to put in an LVAD, if they need bypass grafts or they need a valve done, we're going to do that while we're in there. We can go ahead and go next, Caitlin. So, this is the acronym that everybody likes to use, or when should you refer patients? When should you refer them for advanced heart failure evaluation, or, for advanced therapies? And I need help. If the patients are on IV inotropics, refer them to advanced heart failure. Your patients are NYHA class 3B or 4 and persistently elevated BNPs, refer them. If they have end organ dysfunction, serum creatinine's, greater than 1.8 or BUN greater than 43, refer them to heart failure. Any patient with an EF less than 35%, they're getting multiple defibrillator shocks, hospitalizations, just one. They've had one hospitalization for an exacerbation of heart failure, refer them for evaluation for advanced therapies. If they have edema or elevated PA pressures, despite escalating their diuretics, low blood pressure, high heart rate, send them over. And then, the progressive intolerance or down titration of their guided medical medications. So real important, and you can refer these patients to our clinic, and it can be like, Mr. Smith, he's on the brink, he's doing okay, but we'll see him back here in 6 months and you can continue to follow with him. Or, Mr. Smith's pretty sick, and it's good to kind of get him in here sooner rather than later. And it gives us a lot of options and a lot of things to talk to these patients. So just, referring to the heart failure clinic, I think really helps to evaluate these patients. So we can go next, Caitlin. So again, this talks about timely patient referrals. I talked about on the previous slide when we talked about the NYHA classes as well as the INTERMAX scores. This shows you the outcome when we the outcome of the survival rates as well as the reduced hospital stay when we VAD these patients when they're a little bit healthier than, say, cardiogenic shock. So it shows you the research shows that if they're 4 to 7 INTERMAX, they do a lot better. They have 1.9 times higher survival at 3 years and a 27-day reduction in the hospital length of stay. So, but yet 17% of VADs are implanted in that profile of INTERMAX. Everybody's usually less to the 1, 2, 3s. We can go ahead and go next. So here, I guess this is my last slide. Sorry, they're just coming through. This is our contact resources. There's a VAD coordinator pager on call. There's somebody on call 24/7 for the VAD team. Typically it's me. I'm Monica Thomas. I'm the VAD coordinator. Ellie Donaldson works at the VA in Pittsburgh, works here with me as well. She's a program manager, covers call. And then you can always get a hold of a VAD team attending. If you call the Mars line and ask to speak to, the VAD attending on call, or, the heart failure doctor on call, you can always get these guys, 24/7. Somebody covers that service as well. So, don't hesitate to call us if you need to send us a patient or get a hold of somebody because one of our VAD patients showed up in your clinic and you have questions. We're always available to you guys, and we can, share this information out to you or take a picture of it. I think that's it. Is that my last slide? Okay.
It is. Sorry, I was on mute.
No, that's okay. Does anybody have any questions or? And I think the first session it's recorded. Caitlin,
I did.
So if you didn't get to see the first session, that.
Yep, it went up on our YouTube page, so everybody can refer back to that one, and then this one will later after I get back to work.
Wonderful.
So I know a couple people jumped on a little late, so I'll let them think about it. You did say, let's see, that how long does it take after you put in an LVAD, like recovery time generally?
So typically, here's what I tell patients. They usually spend 2 weeks in the hospital with us. That's no emergent, so no adverse events. Everything goes, if this is a smooth sailing course, everything goes well. It's typically a week in the ICU and a week in the cardiac step down, and then we send them home. And then we do frequent follow-up with them. Initially, they see us every 2 weeks, every 4. But I tell patients, don't expect to get back to feeling 100% until you're right at that 3 to 4 month mark. Because the sternum, we go in, full sternotomy, so it's going to take 6 to 8 weeks for the sternum to heal. And so, but that, for them to feel better from that point and the pain to kind of start to go away. And then it usually takes them another, a little bit of time after that to get used to all the equipment and kind of learn how to live with an LVAD and live with the equipment and the frequent doctor's visits and the frequent blood draws and the frequent monitoring. And then usually these patients hit that 3-4 week mark and they're like, all right, I'm ready to go. When can I go to Florida? I want to go to Alaska. Like you said, I can enjoy my life. I want to enjoy it. So, then we start letting them, okay, we'll let you go these places. Just kind of tell us where you're at. And maybe if you're going to be there for an extended stay, let us touch base with a local VAD center in case you have complications. So.
Awesome. Well, we did have a question chatted into us. So Lucy is on the call, and she was wondering if there's any age cutoff. For example, would an 80-year-old still be able to get this if they were full of life besides heart failure quality?
There is technically no age cutoff for these patients, as long as they aren't in other irreversible end organ damage. If they're a functional person, and we look at it, you're talking a good, healthy 80-year-old that's spry, moves around, has good social. These patients have to have good social support because they need help when they first go home for like 4 to 6 weeks and they can't drive. They have a good social support system. They're no other irreversible end organ damage. We would definitely consider it. There are patients that have VADs that are 80 years old. I mean, the VAD patients that we're doing this week, I have a 74-year-old and a 76-year-old, very healthy, very active men minus their heart failure. So, and they don't have, they do have some kidney dysfunction, but a lot of that we believe is from low output and the heart failure itself. So.
There was another question. The longest duration an LVAD has been in place and functional?
Oh, I just heard that number. I want to say it's over 10 years. I don't know if it's 12 or 13. We're in the teens for the longest functioning LVAD. The average life of these, we tell patients, about 4 years. And whether that be that the pump gave out of the body, a lot of times with the pumps improving, it's the body. But we tell them they get an average of 4 years. There are patients that are on pump greater than 10, but we tell them to expect 4 years, which doesn't sound like a lot. It's kind of depressing, 4 years. But typically when I walk in a room, it's, 6 to 12 months at best. So it's, 6 months or 4 years. A lot of people say, well, I'll take the 4 years. But there are patients that live longer. Just kind of depends. But like I said earlier in the lecture, it's kind of not with this destination therapy and long-term use of these LVADs. It's not if you have an adverse event. Right now, it's when, because it's over the course of time, some things, you're going to have some type of adverse event with this. So the goal is, my patients that are destination therapy, and I know they can't be transplants. We don't harp on this with them, but my young patients, my 30-year-olds that continue to smoke or don't want to drop their BMI or don't want to listen to, the medical advice we give them to get them on a transplant list, we tell them that all the time. Dr. Hagema says it's not if, it's when. And every day you're on a VAD is one day closer to death. Just to, not to scare, I guess to scare them a little bit, to say, you quit smoking and you could get a heart. And, that's kind of right now still the standard, standard of care.
So kind of to follow up, I know there are stipulations for heart transplant, and I think you went over them last time, but what were the stipulations for LVAD?
So for a patient to get an LVAD, we do a pretty full workup on them. They can't have any type of, if they've had cancer, they need to be 5 years out and in remission from the cancer, 5 years remission. They need to have if they have any end organ dysfunction, any kidney, liver dysfunction, we need to know that it's reversible, that we're going to be able, that it's due to the heart failure, to the low output state. We look at to make sure that, they've had whatever's been recommended by the American Cancer Association in terms of cancer screenings. We get all that done. So if they haven't had they're over 50 and they haven't had their colonoscopy, with their colonoscopy done. We look at their, coronary arteries to see, is this a coronary artery thing? Do they have coronary artery disease? Is there any other issues there? I'm trying to think what else we look at. Social support. That's huge. These patients have to have a good social support system. We have to know that they're going to be compliant. We don't say no to patients that do drugs, but we ask them to go through a drug rehab, and prove that they're going to come to us. They're going to, stop doing drugs and we're ready to take care of themselves. The thing with patients doing drugs or being alcoholics is, they kind of don't really care, take care of themselves. So we want them to be compliant. Non-compliant VAD patients are an absolute nightmare because they don't take their Coumadin, they clot their pumps, and it just becomes a yucky thing. So compliance and social support are really big. And then throughout our workup, we just kind of look them over head to toe to see, do you have something going on with you that's going to prevent you from living at least, 1 to 2 years? Do you have, if you have cancer, chances are you're not going to get an LVAD. We're going to have to treat the cancer. So.
Thank you for that didactic. It was wonderful.
You're welcome.
Does anybody else have questions? I know several people jumped on the call.
Insurance issues. Okay. Yeah, you have to have insurance to get an LVAD, and we work with that. I have a financial. Part of my team is the director of finance and the supervisor of finance, and they come to all our meetings and discuss patients with us. And we review, as soon as we see a patient, we start reviewing their financial criteria, their finances, and say, okay, well, not finances, their insurance. What kind of insurance do they have? A lot of these devices need prior auth, and we have to meet criteria for it to be approved, or the patient has to meet criteria. But if they're just a Medicare patient with no supplemental, we work on getting them a supplemental, because after the LVAD, Medicare's only going to cover 80%, so the patients are going to be responsible for 20% of their doctor's visits, 20% of their supplies, 20% of testing. That adds up quickly in the world of LVAD. So we definitely work with these patients to get them supplemental. If they come in with no insurance, we work to get them insurance. We had a patient that came to us. He came out of Kentucky. They said, he had a big MI down there, blew out his anterior wall, and needed an LVAD. They said, we're not going to VAD you here. You don't have insurance. So they send him away. He goes into, an exacerbation of heart failure, ends up in RER. We start working with him. We get the financial team on board. We get him covered. To get his LVAD, we get him covered with West Virginia Medicaid. And then come to find out, throughout all this course of working with him, he's a veteran. So we get some VA. We work with the VA to get him insurance. So we do have people, financial advisors and people that work on our team to get these people the insurance that, that they can afford or that they need to help them cover this. Because the last thing we want to do is put a device in somebody and then they're bankrupt. They lose their house because of the medical bills from it. So yeah, we do take that into consideration and have people that look at that.
All right. Does anybody else have any questions about this or about anything else you wanted to bring up on this session? I did want to make the announcement / plea that we do need cases, or at least questions, to continue basing the didactics and the information off of. I think I said when we started, Dr. Sokas was here with me today and yesterday, so I think we'll possibly start doing like mock cases or case studies or something, just to show simple versus rough or however.
She's the one who signed the waiver. Yeah. all that kind of stuff.
But were there any other questions?
Yeah, no, we were, when we first got started with that department, and we were talking about the diabetic medication. Oh, yeah. And we were meeting, or she or maybe not or something. Yeah. And then anyway, so it'll just be interesting to see.
All right. So let me see. Our next session is going to be June 7th. So that's several weeks away. We have time. So if you guys want to hear about anything, if you guys have questions for Monica, that I know you guys are thinking about all of this and, you know, need time to consider it and everything. So just let me know and I can send those to her. We can ask her to be back on another call soon to answer all of those. Okay. Anything else we want to talk about right now? I'm sorry about the noise behind me. I hope you guys can hear me. All right, guys. Thank you again, Monica. Thank you so much.
Thank you.
Yeah.
Thank you.
We'll talk to you all later.
Okay, thanks. Bye.
Bye.
You're like, right? Yeah.